Okay, welcome everyone. Thank you for joining us today. My name is Renu Sinha. I'm the founder of Healing Spokane, and we have a nice lineup of speakers today. We are going to provide, our mission is to provide unbiased, scientifically based education for both the public and healthcare providers. And we hope through education and collaboration, we can improve the health of our community. And we tend to follow National Center for Complementary and Integrative Health ideas on medical disorders. So thank goodness the government is back up and running. I was worried that the NCCH wouldn't be around. So there's a growing interest in complementary medicine amongst consumers as well as healthcare providers. So I think it's important that we all look at it as a consumer, but also as a provider. Now, tonight, we're not going to be diagnosing or giving an opinion on treatment for any individual. It's just purely for education, so keep that in mind. Our topic tonight is very relevant, especially in a stressful modern society such as ours. Sometimes we don't pay much attention to something as simple as sleep because, well, we're just so busy. But you'll find out that we have more in it than we thought. And according to the National Institutes of Health, 70 million of us have some sort of sleep disorder. And most of our sleep problems have to do with our environment and lifestyle, or can be exacerbated by our lifestyle. And there's an estimated $16 billion spent in the US every year on treating insomnia. And we'll have 6 different approaches to insomnia today. And you'll see some overlap, but everybody looks at this disorder with a different lens, so we can get a big picture. And you'll appreciate that nothing is a quick fix, but working together, we can actually help each other. We're gonna first focus on conventional medical therapy and then go beyond the traditional treatment that we're familiar with. And after the presentation, we'll have a panel discussion where we'll have question and answer. So I'd like you to hold your questions until then. Our first speaker is Dr. Don Howard. He's a board certified pulmonary, critical care, and sleep medicine specialist. What do you not have board certification in? He's going to talk about the standard treatment or approach to insomnia. Dr. Howard?
Thanks. Thank you very much. To start off a little bit about insomnia, I'm going to give the MD perspective briefly. You know, it's really the treatment of insomnia as a group treatment. Unfortunately, you commonly don't have all the resources to adequately treat insomnia, and most medical doctors end up using medication because they don't have some of the people they need to do other type of treatments. I'm going to give you a brief overview of insomnia. First of all, what is insomnia? Well, it's pretty simple. It's either the inability to fall asleep, the inability to stay asleep, or waking up and can't get back to sleep. Now, most people have insomnia usually have a combination of these things. It's much easier to treat if you're using medication, the ability to fall asleep than it is the ability to stay asleep or waking up early and can't get back to sleep. Briefly, waking up early and cannot go back to sleep is fairly classic for depression, though it's not diagnostic, but most people that have depression and anxiety have more trouble with waking up early and can't getting back to sleep, but they can have any of the above. So what causes insomnia? Well, just briefly, first of all, we don't have a very good understanding of insomnia, but we have a wake system in the brain that sends signals to keep us awake, and we have a sleep system that sends the signals to sleep. Okay, people who have insomnia are kind of stuck between these two systems. When they come to see you, commonly when I see people with insomnia, it's not insomnia that's been around for a couple weeks, it's insomnia that's been around for 10, 15, 20 years. And that is a very complex thing because they've developed other things besides just acute insomnia, which is easy to treat. How common is insomnia? Well, you're looking at up to 50% of individuals will have insomnia at some point. Up to 17% of individuals complain of chronic insomnia, and 10% of individuals have insomnia that actually affects their day-to-day life. So physiological consequences, people that come in to see me complain mainly of fatigue. We have something called the Epworth Sleepiness Scale score where you fill out this questionnaire that tells if you're sleepy, like for narcoleptics, sleep apnea, things like that. Most narcoleptics, a normal score would be 0 to 10, and they'll score a real low score because they're not sleepy. Most insomniacs, they don't sleep well, but they don't complain of being sleepy, and they can't nap either. So mainly they complain of fatigue, and they complain of just being lacking energy, lacking drive, concentration issues, and many of the other things in here, stress, physiological, psychological stress, decreased quality of life, and decreased performance. So we have two different definitions of insomnia. First, you have an acute insomnia. Now, I never ever see this. The primary physician probably sees it because, it usually only goes on for less than 3 months, usually only a few weeks. It's usually associated with some type of stress in your life. A loss in the family, loss of an animal, pet, a stressful time you're going through in marriage, whatever it is. It comes on acutely and usually resolves on its own. It doesn't usually require treatment as much as just education of what it is and time, and it will go away. There are some people who I would recommend maybe using medication for a short period of time, only because if your insomnia goes on long enough, then you end up getting a chronic insomnia. So there is a role for some people to use short-acting medications for that, but only for a short period of time and only as needed, not every night. Chronic insomnia, on the other hand, lasts greater than 3 months and tends to be a much more concerning thing. Cases that we see in the sleep clinic really have been going on much longer than 3 months. Like I said, commonly they've been going on for decades by the time they're sent to us, and they've been on all these different pills and different things to try to fix their insomnia, none of which usually work. So most insomnia that's chronic is commonly associated with comorbidities. So these people don't come in and say, I'm perfectly healthy. I go to bed at the same time, I get up at the same time, I eat the right foods, I exercise, I do all these things and I can't sleep. That's rarely the case. So when you take a history, you usually get a lot of things that come up that would cause their insomnia. Specifically, sleep hygiene is probably one of the biggest ones that we're going to discuss briefly. They have poor sleep environments. We've turned the bedroom in from being a place to sleep to an entertainment center. So everyone has a TV in the room. Everyone has their their phone active. Everyone has their computer going. Everyone, it's not quiet. Their husband snores. It's not an environment like it used to be in the 1800s where you went to bed, you slept, and then you left the bedroom and you went on with your day, and then you didn't go back until it was time to go to bed again. There is one type of insomnia called idiopathic insomnia. Now, these are the insomniacs that no matter what you do, you can't find an underlying cause for, and it's been going on usually since they were fairly young. And they probably have a problem with their sleep-wake mechanism that you're not going to fix. Now, I believe that we should do all the things we're going to talk about tonight, but a lot of these patients will be insomniacs most of their life, and a lot of them will require medication to get some type of sleep. So as I said here, usually at an early age, there's usually a family history of insomnia, unresponsive to non-pharmacological therapy like cognitive behavioral therapy and those things. And basically, as I say, the sleep mechanism is basically broken. How do we diagnose insomnia? A lot of patients that come to see me want to know if they're going to get a sleep study. Sleep studies really are almost contraindicated in insomnia. They rarely tell you why someone doesn't sleep. And you're not going to find out anything about an insomniac by watching them lay in a sleep lab awake, because they're just restless, and then the worse it gets, and pretty soon they slept maybe an hour, and then we actually review the studies with them in the morning, and then you're reviewing all of this awake data that tells you nothing. So I tell patients right away that rarely is it recommended that they have an overnight polysomnogram. So mainly we use diagnostic history. Sleep hygiene is really important, and you've got to convince the patient that they have to be involved in their insomnia. They have to be willing to make changes if they want to sleep better. So sleep hygiene is like, what time do you go to bed? What time do you get up? Most insomniacs end up spending a long time in bed they might spend 10 hours in bed to get 5 hours of sleep, and that's inefficient. So you want to get them on a set bedtime and set wake up time, and no more than 8 hours in bed per night, sometimes less when you're starting to treat them. Their sleep environment. Commonly, this is a big deal because the husband wants a TV in the room because he sleeps fine. The wife just does it because that's what he wants, and they need to make all these changes. They don't have a quiet bedroom. They don't have a comfortable bed. They have a TV. They're on their phones all the time. They have computers, and it's no different being in their living room watching TV than it is being in their bedroom. And you have to try to get them to change all that, and that's not easily done. They don't want to really change. They want you to fix them by just giving them a pill, when in reality they need to make the changes. Medical problems. That's another thing, a big discussion with the patients is, listen, a lot of insomnia is related to your medical problems. If you have chronic pain, if you have COPD, if you have asthma that's poorly controlled, if you have rheumatological conditions, or all these different things that cause insomnia, you have to make sure those are treated well before you're going to sleep well. And so a lot of people have untreated medical problems that need to be addressed as well. And probably number one is our psychiatric problems. Depression, anxiety, bipolar disorder, these things are the number one cause of insomnia that's chronic. So, and that's difficult to tell because even when patients have depression, they have it treated, they don't always start sleeping well. They might sleep a little bit better, but they don't sleep as good as maybe someone who doesn't have depression or anxiety. So you have to get realistic expectations that if they're sleeping 4 hours now, if they can get 6 hours of sleep, that might be good for them. You might not get them to 8 hours of sleep. Stressors in their life, that's another big one. They're going through divorce, they got a teenager's giving them problems, financial issues, all these things come into play a role in why they're not sleeping well. The psychophysiologic or the idiopathic insomnia, that's the patient has what I talked about that's chronic, no medical problems, no psychiatric problems, good sleep hygiene, all those things, but they still don't sleep. You have to meet all those criteria before you can say they have idiopathic insomnia. Medications can play a role and others. Now, I said the role of a sleep study. Watching someone lay awake doesn't help. In my case, if I'm treating an insomniac and I'm just not making progress, and I'm like, this isn't making sense, why you don't seem to be getting any better, I will occasionally bring them into the sleep lab to look at their sleep architecture. So that can give me an idea of, like, commonly when they come in, they sleep better in the lab than they do at home. And that gives me an idea of what their staging looks like. Stage 1 sleep, stage 2 sleep, stage 3 sleep, REM sleep. Do they go through the normal, sleep architecture that everyone else does? And the answer to that is yes. People with insomnia go through the same sleep architecture as the rest of us. It's just they're not asleep long enough to go through all the different stages. If I think someone has restless leg syndrome, they usually don't need a sleep study. You can diagnose that clinically and treat it. Alpha intrusion is like an awake waveform that overrides a sleep waveform. So when I close my eyes, I have alpha waves. When I open my eyes, those go away. But some people, when they go to sleep, continue to have this awake waveform that overrides the sleep waveform. And you see that in things like chronic pain, depression, anxiety, fibromyalgia. Those are common causes. So it can be helpful to see if they have alpha intrusion. If you think they have apnea at all, they should have a sleep study as well, but I tend to treat their insomnia first, so they'll sleep good enough in the lab to diagnose sleep apnea. Treatment. Acute insomnia, education, reassurance, and time, and follow-up. Make sure they're getting better, because if they aren't getting better and they don't come back, they can develop into chronic insomnia. So usually we don't treat this at all, except for maybe in some cases using a short sleep aid. Chronic insomnia, it's really all about sleep hygiene, sleep hygiene, sleep hygiene first. I give them a sleep diary, I give them a bedtime, I give them a wake-up time. We show them how to keep it. When they come back, they bring their diary. Rarely have they followed the instructions that we have recommended, and they're all over the place with what they do. And then you keep teaching them, you have to do this if you're going to make progress. Sleep restriction, I won't get into these other people are going to talk as well, but like I said, most insomniacs spend too much time in bed. We want them to spend less time. So if they only sleep 4 hours, I don't want them in bed longer than 6 hours. And they go like, what? We can't do that. I'm like, you're only sleeping 4 hours. I'm giving you 6. So if you decrease the amount of time they're in bed, they become more efficient sleepers. Stimulus control is getting out of bed if you can't sleep. Relaxation therapy, we'll get into cognitive behavioral therapy, treat the underlying medical problems. These are all things that are going to be addressed by other people as well, but these are the mainstays of treating chronic insomnia without medication. And they're the first thing we should always do before we go to medication. So I'm not going to get into this too much, but the pharmacological agents that are out there, if anyone knows anything, there's benzodiazepines, non-benzodiazepines, antidepressants are used. Melatonin doesn't really work, but some people it can be effective for. This orexin receptor antagonist is a new medication that's out there. I'm not big on using medications for insomnia, but if you see enough insomnia that doesn't get better, you're eventually, as a physician, going to use some medication. Because you can't, if you're a therapist and you just say, hey, what I did didn't work, they're on their way. But if you're the physician, they're going to keep coming back. And there are times where you can do all you want to do, and they're not going to get better, so you do have to use medication at times. So my recommendations really are to, don't just accept your insomnia. If you're having trouble, seek out help. Go to your primary. I would seek out a sleep specialist to get an opinion on that. Understand that treatment of insomnia requires a lot of patient interaction. You can't go there and say, find a pill. I saw a patient today had been on literally at least 10 different medications. I said, none of this is going to work. I go, you have to make all these changes. And when you make these changes, then maybe we'll start looking at things if you don't get better. But I don't recommend you be on any medication. Be willing to address other medical problems. The biggest one is depression and anxiety. Most people are undertreated. And finding someone to treat them and adequately get it controlled can be difficult at times. And most patients fail to make progress if they're not willing to change their sleep habits. So I tell everyone on my first thing is that if you're not willing to change, I probably can't help you. But if you want to make change, it's like weight loss or exercise or anything else, if you don't make the change, you're not going to have any improvement. And be open to other treatment modalities, which the other guests here tonight will talk to you as well. Okay, thank you.
All right, thank you. Our next speaker is Dr. Pamela Langendorfer. She's a board-certified naturopath in Coeur d'Alene, and she's going to discuss the naturopathic approach.
Thank you. In my practice, many of the people that come in often have sleep issues. And as a naturopathic physician, sometimes people come in complaining about insomnia, but most of the time it's something that they mention when they're coming in with some other issue. And oftentimes when people come in, they've done a lot of the over-the-counter herbs or supplements that you can typically find. Melatonin, for example, 5-HTP, tryptophan by itself. Those are probably the most common things that people have tried when they come in. And I wish I could tell you that there's this one supplement that you can go out and it's going to work every single time and knock you out, but there's not, unfortunately. And the reason for that being is because we're all different. And one of the principles of naturopathic medicine is to find the underlying cause of disease. So when I have somebody come in and they can't sleep, what we do is, or I should say what I do is I start to look at all the other symptoms that they might have going on and trying to figure out what their root cause is and what that trigger is. And sometimes it might be hormone imbalances. So if any of you are in the audience are menopausal or perimenopausal, you might know when the insomnia starts to hit during the perimenopause years. That can sometimes be a trigger why somebody's not sleeping very well. Sometimes it's from nutrient deficiencies. For example, if somebody's low in magnesium, magnesium sometimes can be helpful for that person. Or sometimes people aren't eating very well, and it might be their diet. And if they don't have a very consistent diet throughout the day, they might be waking up because of blood sugar imbalances at night. So when somebody's coming in, I try to give them the example of, think about a tree with a bunch of branches. And insomnia is just one of those branches on the tree. And maybe you have chronic sinus issues. Maybe you have some digestive issues. And if we just start chasing all of these symptoms, all I'm doing is putting Band-Aids on your tree, whether that be with a medication or with a supplement. And the philosophy is a little bit different, where we have to fix your roots, we have to fix your foundation. And so to do that, we're going to talk about the things that you're ingesting. There was talk earlier about sleep hygiene, and that is really important and definitely one of the big triggers for people starting to have more and more issues. Diet, exercise, all this goes together. And sometimes people do need medications because they've done all these things and they're not working. But there's so many things that you can do that I encourage people to exhaust all of these options first. And the one thing I always tell people, no matter what I'm treating, whether it be insomnia or some other issue that they have going on, is if you're trying something, maybe it's a supplement, maybe it's an herb, and it's not working, it's not that those things don't work, it's that that's not what your problem is. And you have to dig deeper and you have to figure out what your trigger is and what your root cause is. Thank you.
Thank you. Our next speaker is Dr. Devin Grant, and she's a postdoc research associate at the Sleep and Performance Research Center at Washington State University, right here.
Right here, across the street.
Across the street.
Yeah, it was an easy trip. Okay, I worked with, just to give you a little bit of background, I'm a mental health counselor and did several years of cognitive behavioral therapy with Dr. Howard, straight out of grad school. So after I decided to make a transition and go into research. And one of the things that always stuck with me was that when insomnia patients would come in, they would frequently complain about that they have these residual impairments throughout the day. And those are really, really hard to quantify. And that is something that always has kind of stuck with me. So just to give you a little bit of background into my research interests, I was looking at insomniacs and looking at, can I quantify any impairment that they maybe are experiencing during the day. But again, just a little bit of background on that. So kind of I'll try not to do too much data with you, but you know, the reality is that insomnia is marked and it becomes much more prevalent in middle age, as has already been mentioned here, and it's much more common in women. I tried not to believe that for a while, but that is absolutely the case. So when we're young, oh, that's not what I want. How do you do the light? Green up top. Oh, now it's vibrating. Crap. Oh, there it is. There it is. Got it. Okay. So we all start out kind of the same. So our prevalence of insomnia for men and women is pretty low. But as we get to this middle age, there's a big spread. So women kind of go off the rails here. What's going on there, we don't quite know. I have my own theory on that, but I think a lot of things start to happen here. Kids are growing up, there's stress, there's other things going on, maybe in relationships, older parents are dying, and menopause, which we have to look forward to as well. No, it's not advancing. I'm failing. There it is. Okay, we got it. But there's also a lot of associated health consequences with insomnia. And one of the things I think is really important to point out is a lot of times patients will come in and say, my pain is caused by my insomnia. And I think what's really important to point out is that it contributes to your insomnia. But I think it's very important to really differentiate a contribution versus the cause. Now, that being said, people do have tendencies, as we've already kind of discussed here, to develop, they're more likely to develop depression or anxiety as a result of having their insomnia. And there's also been some good research out there that's looked at insomniacs who sleep less than 5 hours a night. So, and they notice that in those individuals that sleep less than 5 hours a night, they do have a higher likelihood of developing things like hypertension or type 2 diabetes, and do have increased risk of cardiovascular events. So there is some link there, but I think what's really important before we go to, my insomnia is going to force me to have a heart attack, is just to look at the fact that there's correlations but not necessarily causation, and that's really important. So I did kind of an interesting study in our lab across the street, and what I did is I brought some individuals with insomnia into the lab, and I gave them a battery of cognitive tasks every 2 hours. And what I was hoping was to find that these individuals actually did really well. And so what I did is I had some individuals with insomnia, and then I also just had some healthy, normal sleepers, and then they underwent 38 hours of sleep deprivation, which seems kind of mean, but it's actually pretty easy to get through. And every 2 hours, we gave them a reaction time test. So you can see that here. They sat at a computer station, they were presented with a visual stimulus, and then they had to press a button every time it popped up, and we would look at their reaction time. So a normal, healthy individual who isn't being sleep deprived will have what we quantify as 0 lapses, and lapses are reaction times less than 500 milliseconds. So everybody should be able to do that with no problem throughout this test. But if I sleep deprive you, what's going to happen is your lapses are going to start to go up. So this is what I found for their performance. So the gray is just healthy, normal sleepers that are undergoing 38 hours of sleep deprivation, and the black is some insomniacs that I had in the lab. The clock time is along the bottom, and their lapses are here along the y-axis, and more lapses equals more impairment. So what I found was that during the normal day, the two groups did relatively well. They were lapsing very infrequently. But as soon as we started sleep deprivation, so they weren't even sleep deprived that much, maybe like 2 hours, the insomniacs kind of took off. So they had this huge impairment of sleep deprivation, whereas the normal healthy sleepers that were being sleep deprived were also increasing, meaning they were becoming more impaired as they were sleep deprived, but not nearly to the magnitude that insomniacs were. And then we gave them some recovery sleep, and then we looked at their reaction time after they had recovery sleep. And you can see that both groups came back down to pretty close to baseline, but the insomniacs were still a little bit high. So the take-home message on this is that I think it provides some credence to patients that come in and they say, I'm not performing very well. And I think we have some objective evidence that that is actually the case. And especially for individuals that do shift work or somebody who has a sleep disturbance who maybe just has to stay up a couple of extra hours. If you push them a little bit further, we do start to see these very drastic impairments. Okay, so to kind of transition, because I know we're going to start talking more about treatment, and I did a lot of cognitive behavioral treatment with insomniacs, but this is just a little bit of data to kind of show you that there are benefits to treatment, and it does actually physiologically help you. So what these two graphs are showing are what individuals look like before they start their behavioral treatment and after they finished their behavioral treatment. So one of the markers that they used was something called cortisol. Cortisol is a hormone that our body releases naturally throughout the day. It's also considered a stress hormone, but it does provide some protection. So for instance, if like a lion or something were to jump out right now, I would really hope that my cortisol peaked really quickly so I could run out of the room. And then our cortisol is naturally the highest right after we wake up in the morning, which seems kind of counterintuitive, and we don't even really know why exactly that happens. But there are some ideas that maybe it's to help kind of get us ready for the day. So what they found was that for the individuals in the open squares, so this was before they had treatment, their cortisol levels were pretty low. And then after treatment, they stayed low, but what we see is that there was an increase in cortisol in the morning. So what that really means is that individuals are starting to normalize. So they were starting to have kind of normal rhythms after they went through behavioral therapy, which is a really good thing. And then secondly, we're looking at body temperature. So body temperature is something that fluctuates throughout the day. When we're asleep, our body temperature is really low, and that's good. That means that that also helps us to promote sleepiness. And then when our body temperature is high, that's when we're most activated. And what we can see here is that at baseline, the individuals had a much higher body temperature, and this is throughout the middle of the night, so not necessarily as conducive to sleep. But after they went through behavioral therapy, their body temperature went down, so it's much more conducive to sleep. So there are actual physiological changes to going through these therapies. Okay, that's all I have.
Thank you. Our next speaker is Dr. Sean Smitham. He's a clinical psychologist at Fairchild Air Force Base, and he's going to discuss the psychological approach to insomnia.
Let's see, can I borrow the clicker? Thanks. So we're going to talk about the frontline treatment for insomnia, at least from a psychological standpoint, and it sounds like we're in agreement for most part with the panel is cognitive behavioral therapy for insomnia. Most people are going to start with their sleep aids, but again, that's contraindicated for most insomniacs. The behavioral treatment for insomnia has really good efficacy evidence for it. So I'm just going to give you the overview. Maybe not. Oh. Okay, so there are no slides. That's okay. We'll talk about it in general terms then. So cognitive behavioral therapy basically is about 4 to 8 sessions. The most difficult thing for cognitive behavioral therapy is to educate people on sleep hygiene, because everybody thinks they're doing it, but they're really not. And so getting them to accept the fact that they have to make changes to their lifestyle, that they have to make changes to the way that they sleep. And so the first place we start is telling everybody that their bedroom should be like a cave. It should be dark, it should be cold, there should be nothing going on in there but sleeping. The exception is sex. If you're adventurous, that doesn't even have to happen in the bedroom. But sleeping only in the bedroom. No TVs, no computers, no iPads, no checking of the phone. So typically when I'm working with people, I will start there. Is your bedroom like a cave? And this is what it looks like. Removing all the external sort of light that might be there. Helping them understand the relationship of temperature, so it's a cool place temperature-wise. And then also people on their phones, like people want to check email all the time. My wife is one of the biggest culprits, and then she complains about not being able to sleep. So I typically tell people that last hour before bedtime, no electronics. If you want to read, fine, but don't turn on the TV. Don't check the computer. Don't check your phone. Ideally, I would love it if you were charging your phone outside of your bedroom. People will say, well, I won't hear a phone call. Then I remind them that their grandparents had phones outside their bedroom. The world seemed to function just fine. So we have to do a lot of problem solving around that. The other thing is alcohol. People like to have a nightcap. They think it's helping their sleep. It really isn't. It might help with sleep onset, but then it will disrupt their sleep later on. So we talk about the role of alcohol. And then really educating them about, and I'm going to talk in really sloppy terms, so I apologize, that they have two competing forces working with sleep. One is a downward sleep pressure that accumulates as you're awake, that makes it, pressures you to seek to sleep more. And then the other one is an upward vitality, circadian rhythm, the energizing force that's coming up. And where the insomniacs get trapped is between those two forces. So educating them that these things are happening. If I can educate them about the circadian rhythm, there's an ebb and flow to your energy throughout the day. You're going to have peaks of energy up through the morning, and then about 1 or 3 o'clock in the afternoon, you're going to have a decrease in energy, and then you'll have a peak of energy again, and then you'll have another more severe decrease in energy right around typical around 10 o'clock at night until 6 o'clock in the morning. At the same time, you have what's called sleep pressure building up. Now, if you're taking naps throughout the day, you're decreasing the overall sleep pressure. What we want to do is increase the amount of sleep pressure so that we can set the stage for you to have a restful night's sleep. With that rationale in place, then we go and establish a very firm wake-up time. So we don't start at the bedtime. We start at wake-up time. When do you need to be awake? When do you absolutely want to be out of bed? And then we get that established, and we have them complete a sleep diary for a week or two just to get some data about where they're actually, how that downward sleep pressure is being affected by naps and how much time they're actually spending in bed. Now we can start to tweak that once we get that data. Getting that data, really hard, because everybody thinks they're doing it, but they're not. So they come in the first week with their sleep data, and they said, I did it, and then I have to go back through it and say, pretty close. What I really need is for you to focus on when exactly did you go to bed, how many times did you get up, how much time was in your bed, and how much time were you sleeping. There's usually a little pushback and frustration there, and so then they come back with another week of sleep data. By that time, I have a pretty good data set to work with. The time in bed thing gets to be really tricky because people think I'm in bed and so I'm setting the stage for sleep, but you're actually not. If you're an insomniac, what you're actually doing is pairing a lot of disruptive cues. So when your insomniac is laying in bed, they're tossing, they're turning, they're worrying about whether or not they're going to get a night's sleep, or is it going to be like the other night. I'm never going to sleep well again. I'm worried about things that are coming up in the morning. I really need to be on my game for a presentation at work tomorrow. All these different things are becoming associated with your bed and your bedroom. So then in the future, that becomes a conditioned stimulus that triggers this agitation, this frustration. And so we need to break that. And so the instruction is, once you go to bed, if you're not asleep within 15 or 20 minutes, get up and get out of your bedroom. Again, don't turn on any electronics. No iPads, no phones, no computers, no TVs. Ideally, you'd be in a low-lit kind of place. I've never had this prescription fail, but I've never had a lot of people pick me up on it either. Take a toothbrush, a new toothbrush, go to your bathroom and start scrubbing. And then, when you're sick of scrubbing, go back and try to sleep again. And again, if you're not asleep within 15 or 20 minutes, go back and start scrubbing your bathroom again with your toothbrush. At the very least, you'll have a clean bathroom. But it gets the point across that I don't want you to be doing anything that's going to be with electronics that's going to be disrupting your sleep rhythms. Once we get a good high percentage of sleep efficacy, the amount of time that you're in bed and actually sleeping, now we can start to expand backwards when you're going to sleep. So we try to compress your sleep time. So you may be going to bed, if you're sleeping only 4 hours at night and you need to be up at 7 in the morning, then we start with you going to bed, say, around 2:30 or 3 in the morning. So you stay awake up until that time. Then as you get really good about being efficient sleeping in that time, we back your bedtime up 15-minute increments. So it can be a process, but I've seen it work really quickly. The biggest thing is to get buy-in from the people that are doing the treatment. But that just takes some patience and education. And then once they start to experience a little bit of success, then we have to plan for relapse, because there are going to be times where you just don't sleep well. There is a big presentation coming up, or there is some kind of stressful event going on. And for them not to go back into those old habits, especially the cognitive habits of catastrophizing, oh my gosh, it's happening again, oh my gosh, the treatment hasn't been successful. And so we just walk them through a rational disputing of those kind of thoughts. So that's a quick and dirty version or overview of the cognitive behavioral treatment for insomnia.
Great. Our next speaker is Corinne Fotheringham. She's an integrative nutritionist, and she's going to talk about the nutrition approach to insomnia.
Thank you. So a lot of the nutrition just comes back to the basics when we talk about insomnia and sleeping habits. In my practice, I do assess sleep with the clients that I work with. And surprisingly, I do work with a lot of teens, and they are actually already on sleep medications to help them fall asleep. Can anybody guess a reason why teens might be on sleep medications? Yeah? Yeah, I think stress is always a huge consideration. So that's definitely one. I agree with that. I also work with eating disorders. So that could be it too, because there's also anxiety and depression that are very commonly linked with the development of the eating disorder. And as we know, that can be a factor in insomnia and sleep disturbances. Also, guess what are sold at schools nowadays? Yeah, Red Bulls and Monster energy drinks, and Starbucks is really the cool hip place to be. So that's something that I like to talk a lot, especially with my adolescent clientele. A lot of them are consuming quite a lot of caffeine in the form of energy drinks and coffee. And to be honest, I just don't really think that's appropriate for that age group. We don't have a lot of great data on what the long-term effects of that might be on growth and hormones. So that's something that's a place that I always like to start, especially with that age group. Looking at caffeine intake. We really shouldn't have caffeine intake less than 8 hours before we're trying to go to sleep. So if anybody's able to do the math, it's usually noon to about 2 should be the last caffeinated beverage for the day. And a lot of people have a really hard time with that. So that's a really good place to just get the conversation going around caffeinated beverages. A lot of those beverages are also very high in sugar and pretty highly refined. They're very processed, and they don't really offer a lot of nutritional benefits. They don't have really vitamins or minerals to speak of, and they're just offering a lot of empty calories. So that kind of opens the door for another conversation on, okay, let's go back to the basics with nutrition. Let's think about whole foods from their natural state and shift the focus of what diets should look like. Consistent nutrition, I heard you touch on that, and consistent nutrition throughout the day is so important. So starting first thing you wake up in the morning, get ready for the day and nourish yourself. You've gone usually 8 to 10 hours without having any kind of food, so our body really needs to have some energy. And a balanced breakfast can be really important. So in some cases, some of the clients that I work with, breakfast may not be the best idea, but the majority of people really do need some breakfast in the morning, and it does need to come from a wide variety of macronutrients. So ideally have some sort of fat, protein, and carbohydrate. It can be really simple. You don't have to wake up and make a 5-star meal in the morning. It could just be a hard-boiled egg, maybe depending on what kind of foods you like. It could be some brown rice, could be some whole grain bread, just something really easy. A lot of people like to get some veggies in the morning. It's totally up to you and what you like to eat, but having a good start to the day can be really beneficial. And then consistent intake throughout the day. So we're all so busy and so stressed out. There's a lot to do at work. But making the time to have some lunch is really important too. The longer that we go without having consistent nutrition during the day, the harder it is for our bodies to maintain our blood sugar and our hormone levels. So taking that time to, once again, nourish your body, give yourself appropriate nutrition during the day to keep you fueled until dinner time. For a lot of people, 3 meals, maybe 1 snack or 2 snacks a day is a really great place to start. So those 3 meals, ideally, the lunch would actually be the largest meal during the day, and then dinner being not as large. I feel like in our society, just the American society, dinner is typically the largest meal of the day, and that can just put a lot of pressure in metabolizing that in our bodies right before going to bed. So it's best to eat no more than or no less than 2 hours before bed, and then ideally more like 3 hours before bed, and have it be a smaller meal. Obviously, you want to eat enough so that you're not going to bed hungry, but you don't want to have a really large meal where it makes it challenging to fall asleep at night. Some of the nutrients of concern other than caffeine, I think you touched on alcohol, where initially if you have a nightcap before bed, it can, kind of make you feel drowsy a little bit, but it does actually cause sleep disturbances later after metabolizing the alcohol. So it's best to not have one of those before bed, or drinking it earlier in the evening or late afternoon if you need to. And then with other nutrients, vitamin C can actually be really, really helpful for our adrenal gland support. So once again, kind of this idea of hormonal regulation, cortisol production, we kind of touched on that earlier. Vitamin C, a lot of people don't get a lot of vitamin C during the day. And it's one of those vitamins that our body just doesn't naturally produce. We have to have it from outside sources, ideally fresh fruits and vegetables. So one of those that's so great this time of year are fresh oranges. Obviously, they're not local, but really great source of vitamin C. And also, I think people forget about sweet peppers, but those are really chock full of vitamin C as well. Magnesium, I heard that one come up earlier too. So a lot of Americans don't actually receive their or consume their recommended daily allowance for magnesium every day. It's a very common deficiency for a lot of people. So magnesium actually is really easy to get as long as you're eating whole, nutritious foods. Nuts and seeds are really, really high in magnesium, as well as leafy greens, vegetables. Their whole grains are also really high in magnesium, so those are great places to start in terms of your nutrition. And then I just wanted to kind of close with this idea that I think when everybody thinks of sleep, they think of tryptophan and Thanksgiving and the big turkey dinner, right? You eat turkey, you go to sleep right away. There is a little bit of research out there to support the fact that tryptophan is a precursor. It's an amino acid. It's a precursor for serotonin, which helps us feel calm and drowsy. So there's a lot of great food sources out there besides turkey, and it's actually also helpful to eat that kind of amino acid that comes from protein with carbohydrates so that we can better metabolize it and it's converted to serotonin more easily in our system. So having like a small snack before bed can work sometimes for people. Oatmeal is a great food to incorporate, and it's also nice and warm. A lot of people like to feel warm before going to bed. Sometimes the temperature of foods can really be helpful too. Other people might like something cold like ice cream, but a better alternative to that might be some frozen yogurt before bed that has a combination of protein, the amino acid tryptophan, and a little bit of carbohydrate in it as well to help that serotonin production. So just some things to keep in mind as you evaluate what you're eating and how your eating habits can affect your sleep patterns.
Thank you. Our last speaker is Shawn Brow. She's a nurse anesthetist who decided to be a certified professional yoga therapist, and she's going to talk about yoga and meditation.
Thank you. So if you do suffer from insomnia, you probably at some point had someone say, well, have you tried yoga? So this comes up a lot. No matter what your problem is, it seems like someone's going to suggest yoga. So what is it? How many people have done yoga? And some of you I recognize. Is it about the body? Is it about the breath? Is it about your mind and consciousness? Yes, it's about all these things. I wouldn't try this pose before bed. I wouldn't try this pose, period. It's a beautiful pose by my friend Michael Stone. The word yuga, that's good. Yoga in Sanskrit, yuj, is union or to yoke. We're thinking of yoking the body, the mind, via the breath. So the breath is like this thing with tendrils, and it tethers our body and our mind. It makes that connection for us, and also our spirit. So it does have to do with the body, the mind, and our emotional energies and our spiritual energies as well. The other thing about yoga that most people don't appreciate is there's more than just the pose. And I intentionally put that picture up there because that's what we see on the magazine. Wow, look at that pose. I wonder if I could do that someday. But we lose the focus of the other values of yoga, and there's 8 limbs in classical yoga. We like to think that we start with moral and ethical principles, which are the yamas and the niyamas, things such as being kind or nonviolence, as sometimes it's described, truthfulness, being content with where we are at any given time, so getting away from that ego voice and the inner critic. As we go down the list, asana comes up. Asana is the posture, one of the limbs. So these shapes that we put our bodies in. Why do we put our bodies in different shapes? We can apply stretch, we can release tension, neuromuscular tension. If we bring intention to that via the breath and our intelligence, we can also create release of different other energies in the body. Mental energies build up emotional energies. So that puts us, whoops, go back here. That puts us at asana. There's also pranayama. This has to do with breath. I call it breath extension. I try to avoid the word restraint or regulation, but it's working with different patterns of breathing. And as you know, and we'll see a little bit later, the breath is very key in helping us learn to relax as well. Pratyahara, and these last couple, Dharana and Dhyana, these all have to do with consciousness and the mind. So back in the day, I don't know, they say it's 3 or 4 or 5,000 years old. I don't know, I wasn't around. But it's a very old practice, yoga. And in the day, it was much more appreciated as a mental and consciousness practice, i.e. the meditation part of yoga, rather than what the pose is about. And perhaps they were sitting around in caves and meditating all day. Wouldn't that be nice? No cell phones there. And at some point, perhaps they got very tired of sitting in one place for very long times and contemplating the universe, and they started to move. And they looked around at their environment and said, I kind of like the way that dog looks. And they started mimicking things in their environment, which is why many of the yoga postures have names that reflect the environment. Downward facing dog, or waterfall pose, or whatever have you. And there's lots of stories attached to some of the postures as well. So keep this in mind as we go, the 8 limbs, and you'll see them come into play here. I drew this up with a few postures. This was from, a suggested set of postures that can help you unwind for nights when you're having trouble sleeping or even just preparing for sleep. But you notice there's extension. This is, whoops, wrong one, sorry for the light show here. Extending the spine, very important. And as we fold, you're going to get stimulation of some of the deep tissue in the body. And the vagus nerve, the wanderer, it's everywhere. Starts in your brain, takes off to your throat, vocal cords, heart, lungs, digestive system. It just is everywhere. The vagus nerve is what kind of slows down and kicks in our parasympathetic nervous system. So postures which can compress can help stimulate the vagus nerve and start bringing more of that nice calmness to our bodies and our minds. You notice here, we're folded down in child's pose, and again, this helps calm and soothe. And this is just what a child would do when they're upset. They're going to turn in and try to recollect themselves. The last one, an inversion of the legs. This can be really helpful. Timothy McCall's done some work with looking at the effect of baroreceptors, actually, and how that interplays with stimulating different hormones through the pituitary and the hypothalamus, and cortisol levels through inversion. So shoulder stand is another one that sometimes is recommended in the evening to help kick in those effects. Have I got to 6 minutes yet? Okay, we're almost here. So I need to jump to just ahead to this one. Pranayama was the limb right after asana. Pranayama, again, the breath. So one of the many, many different types of pranayama is this one, which is very soothing and cooling, is Nadi Shodhana. And this is a pretty easy one to practice. And I'd like to do just a moment with you, if you will play. And this is thought to help equalize the balance of the sympathetic and parasympathetic nervous systems. And if you think of the track of the vagus nerve coming down through the throat, the back of the throat perhaps, into the esophagus and other innervations that it has, you can imagine the breath moving through the back of the throat and stimulating those nerves. So if we could breathe on each side, on each nostril, alternating that, perhaps we can bring balance to these nervous systems. So, if you will, there's a special mudra or hand position, but sometimes it's just hard to do. This is like reindeer hand mudra. But what I would like to offer tonight is a much easier way to do it. Just take your thumb and place it on your right nostril. You don't have to be right or left-handed. I'm left-handed, but it works really well with my right. So we're pressing lightly, but just enough to occlude that nostril. Take a full breath in without occluding it. And as you exhale, occlude it now. So you're going to breathe out the left nostril. Breathe in the left nostril. And when you get to the top of that breath, use your pinky and your fourth finger on the left nostril and exhale. Inhale again on the right nostril. Close off with your thumb on the right and exhale left. Inhale left. Top of the breath, change. Exhale right. Inhale right. Top of the breath, change. Exhale left. So this simple technique of alternate nose breathing, a couple things. I'll bet it was really hard to think about answering your phone or that text, right? Because we brought our attention to the breath. So it reroutes the mind energies to pay attention, which a lot of meditation techniques do as well. So we can be with the breath, not somewhere else. Also, that physiology of working with the parasympathetic nervous system is in play with Nadi Shodhana. Okay, so I'm going to back up. Whoops, where's my magic button here? Back up here. So that brings us to those other branches, the dharana, dhyana, and then samadhi. Those are those three last ones on the 8 limbs. And I mentioned they have to do with the mind. So as we learn to meditate and we get deeper and deeper, we start pulling in other parts of the consciousness, more the subconscious and such. When we first begin, it's just enough to have something to follow, something to focus upon. There's all sorts of different meditations, but they're supposed to give us a sense of calm, help us get rid of the inner critic. They can also physiologically, these techniques lower blood pressure, can help increase our immune response. We've seen a lot of data with the fMRIs now that, yeah, the neuron density and the gray matter's better with people that meditate. And then, Sean, have you worked with the MBTI, the mindfulness-based therapy for insomnia? So it's got its whole name now, or allowing sleep to unfold. So John Kabat-Zinn was one of the, wow, I'm just not getting a hold of this. I don't know where I went. Okay, I'm back. So he was one of the pioneers in working with mindfulness meditation, or the system called MBSR, the Mindfulness-Based Stress Reduction. It's an 8-week course. There's several people in town I know that teach that. A lovely program that works and incorporates a little bit of yoga as well. But his mindfulness is paying attention in a particular way and on purpose, in the present moment, and very non-judgmentally. It's a lot of words, right? But it's being present the best you can in all those ways to create this calmness and the sense of awareness of what is now, because this is when it's happening. You're all here now. This is great. You're listening, you're attentive. No cell phones, no computers, just you and your breath. So we're going to look at that a little bit more and work with just a brief meditation as I close, okay? I think that was the last slide I had. Yeah, we went over that. Practice. So if I were in a circle with you in chairs, I would remind you there's about 7 points of prep for meditation, which is physical things like, how's your head doing? You know, are you like this? So you want to pull up, let the chest lift so your breath is free. And classically, if you can come a little bit forward onto the front of your chair, because what happens if we meditate many times, if you want to get up early in the morning or maybe before bed, these are good times, but sometimes early in the morning we tend to go back to sleep if we're sitting at the back of our chair. So sitting forward can be really helpful to bring a little more attention. The arms are relaxed at your sides, and the hands can just be comfortably placed on your thighs or perhaps cupped, as in a Buddhist meditation. And then with the eyes give us a lot of stimulation, right? So closing the eyes can be really helpful. But I say that as an invitation. Can you open your eyes now? And now allow your eyes. Let the drop of the gaze happen. And then as the gaze comes down, then let the lids continue to close. Notice your body in this place, perhaps circumscribing the shape of your body here. Notice where your body is touching the seat. Notice perhaps the palms where they're placed. And now, if you would, bring your attention to your breath. Without needing to change anything about your breath, just notice it. Notice it in the belly as you inhale. perhaps moving it up through the chest, the top of the lungs, and notice the transition as you exhale. Notice your next breath as though it's the first time you've ever seen it. Notice the quality of your breath. Is it smooth? Are there catches? As you breathe, breathe through the nose, allowing the lips to be just relaxed and soft. Notice also the mind. Maybe there's some positive charges that have already taken you away from the breath. And classically, the mind is very good at either remembering, planning, judging, or even fantasizing. So notice whether that has happened at all in these first few moments of observing your breath. So the mind may wander, but the practice is coming back to the breath. You may leave and come back many, many times in your practice. And this is the training of coming back, beginning again, without judgment. Just coming back to the present moment, back to now. On your next breath, see if you can notice the very beginning of the breath, where it transitions at the top of the breath, the exhale, and the end of the breath. Notice as well, perhaps a brief pause at the end of the breath. As you notice this pause, perhaps cultivating it for just a moment longer as you listen for the body's request for the next inhale. This end of the breath, this place is a very special place. In Tibetan literature, it has the name Bardo, place between. And if you consider it's where we arrive when we're born, before our first breath, and that's also the place where we leave on our last breath. So just a few more moments with the breath. Observing, and being content with what you find. And now slowly, as you're ready, invite the eyelids to begin to rise open, taking the view in front of you, down, and then as the gaze is ready, allow the gaze and the eyelids to open fully. I hope you can take that into your evening and your week.
I'm too relaxed. Okay. Are we all awake now? Okay, all right. Thank you. No insomnia. All right. All right, panel. 1 to 2 pearls or take-home message from your talk that you would like the audience to know.
I'd say for mine would be don't expect medication to be the key to treating insomnia. That's number one. And number two, realize you may need multiple different specialties and modalities to really get to the core of your insomnia to treat it long term.
Okay, thank you. Pamela?
Mine would be to search for your underlying cause as to why you have the insomnia. And oftentimes it's not just one cause, there's multiple factors.
I would say for mine is that allowing yourself to really accept behavioral therapy is not just going to show an improvement in your sleep, but you're also physiologically going to change, and that will be helpful too.
Okay. I think for me, it feels like a big thing, right? Because you've wrestled with it for a long time, but it's not bigger than you are. And so continue to work at it, continue to chip away at it and do the things that may be uncomfortable at first, because eventually you'll find the combination that will help you get some more rest and extended sleep.
I think for me, it's just another form of self-care in a way that you can really truly treasure your body and make sure that you take care of it well. And one of the foundations being really consistent nutrition intake of whole foods throughout the day to make sure that your body has what it needs without overloading it at night after work right before you go to bed.
I'd say beginning again, just like coming back to the breath. As you've seen, there's so many different ideas and ways that we can approach working with insomnia. And I think it's that way with many things that we have. But the body's really good at healing if we allow it everything it needs, nutrition, and just this awareness of how we're treating our body. So not giving up, coming back, just like we do coming back to the breath. The breath is always there for you, and it's one of the nicest ways to calm and relax. And if that can set you in that perfect place before rest, then do it.
Great, thank you. Monica, do you want to come get the mic? Thank you. Great information. Let's give the speakers a round of applause. All right. Dr. German has the microphone for anybody who has questions for our panel. All right.
I didn't know if anybody addressed potential gut bacteria imbalances due to medications like antibiotics or other chemicals. I hear glyphosates interrupting our gut bacteria and how that can interrupt the production of serotonin and the melatonin balance, the hormone balance. So looking at that factor.
Pamela?
Yeah, absolutely. The gut plays a huge role. I think that that's a lot of the research coming out in the past 10 years since they started the Human Microbiome Project. And we do know that most of the serotonin receptor sites are located there in the gut. And I think that that is, still being figured out in terms of is there a specific strain of bacteria that can impact that. But you are right that when you have, when you take different medications, they do interrupt your gut flora. And that's why the diet is such an important piece, and including fermented foods and things like that, because traditionally that's what people did to help to restore that.
Thank you. And then, like yeast is probably a part of that, but I've been hearing a lot of talk lately about parasites and the potential for how that could be affecting our health and our mental function. And is that anything that anybody addresses that we could look into getting help on how to address that potential?
You can do, is it okay if I? Okay. You can do stool analysis for that. And in my practice, I take a broad approach. So as I was talking about putting a puzzle together, and I didn't go into a lot of detail about it just because of time, but the way that I look at it is that we're trying to put together this puzzle. And so the foundation starts with the diet, and then I do different testing that look at stool, different nutrient deficiencies, hormonal status, and so that's how I start to figure out where some of the problem is coming from. And so some people do have those issues with candida or parasites, but not everybody, and so that's why it's helpful to test so you know what you're treating. And you're not just taking a bunch of herbs that you may not need, because the herbs can disrupt your flora just the same as an antibiotic can.
All right, next question.
I guess besides being at this event, when do I know when I need to come seek professional help? I mean, if I'm waking up 8 to 10 times a night, when do I know that it's time for me to come maybe see one of you?
I would say, well, it depends on if you're waking up 8 to 10 times a night but going right back to sleep, or, if you're laying there awake for long periods of time. But I would say anytime you feel like this seems abnormal, that you should seek out help earlier than later. If you're waking, there could be a lot of things that are causing you to wake up besides just, insomnia. That might be a sleep problem or sleep disorder. So I would say sooner than later, because once insomnia kind of gets out of control, it's really can be hard to, get you back to sleeping well. A lot of times you can start with your primary, but if you don't have some experience in insomnia, it's very difficult. And the first thing, I'll be honest, you're going to be given is a pill. And I think that's the wrong way to start. Because insomnia is really much more about a lot of these things we've been talking about: cognitive behavioral therapy, relaxation therapy, all the things, the yoga, all that. If I had someone I could refer my insomniacs to, good referral services for CBT and those things that I knew were good at what they did and were having interest in insomnia, every patient I had would go there, every single one. They would never get medication before they completed that.
I didn't hear the word inflammation. I don't know if there's any relationship that you can help us with, but foods, environment, other things, not infectious type of inflammation, but other. So any correlations, relationships?
Corinne?
Yeah, I think that's a difficult one with inflammation because, well, now we have this big association between inflammation and heart disease and coronary disease and orthodontia, periodontia, everything, associated with coronary disease. I think inflammation is kind of this new wave in medicine that's starting to show what role it plays in a lot of things. I can't quote any recent articles on inflammation and specifically insomnia, but I guess I would say it wouldn't surprise me.
Any other questions? Yes.
I have kind of a question about napping. So, like as children, naps are included, and as we go into adulthood, some people still they feel more rested if they have an afternoon nap. But then others, they'll take a nap because they're so exhausted during the day, and then they'll wake up and they'll feel very cranky. And I was just kind of curious if there's a reason why. And in both of these scenarios, I'm kind of thinking of more normal sleepers, but just like that sleep wake cycle, I'm just kind of curious of.
I think, you can correct me. I think there is good evidence if you're a typical sleeper, you don't have nighttime waking sort of problems, a short nap in the afternoon between 1 and 3 can be beneficial for people. Typically, it's shorter than most people are comfortable with, so 20 minutes. One way to do it is lay down and hold your keys in your hand, so they're out from your couch, and the moment that your keys drop, it's time to wake up. Extending it longer disrupts that sleep pressure later on in the evening. So